In the 20th century, an estimated 191 million people died directly or indirectly from a single highly engineered pathogen.
Yeah, 191 million. It's a staggering number.
Right. But, you won't find this pathogen under a microscope. It doesn't have a viral envelope. It doesn't have a bacterial cell wall. And it definitely doesn't naturally jump from animal to human hosts.
No, it doesn't.
Yet, when you are standing in a clinical setting, whether you are a medical student taking your first history, or a junior doctor managing a busy ward, or even a public health trainee looking at population data, this is perhaps the most devastating systemic infection you will ever study.
Because unlike a naturally occurring virus, this pathogen actively and intentionally seeks out and dismantles a society's immune system.
Exactly.
I mean, it specifically targets the sanitation infrastructure, it purposefully severs healthcare networks, and it deliberately poisons the agricultural supply chains that keep a population alive.
Welcome to this deep dive. We are functioning as your direct companion to Chapter 9.6 of the Oxford Textbook of Global Public Health, which is titled Collective Violence War.
That's right.
Our mission today is to ask you to completely reframe how you look at one of the oldest threats to human health. We are stepping entirely outside the realm of politics, diplomacy, and military strategy.
Completely outside of it.
Instead, we are adopting a strict, objective, clinical approach. We are going to analyze war using the exact same public health frameworks you use every day. Tracing risk to exposure, tracing outcome to intervention, and analyzing the cascading systemic impacts on population health.
And it's so essential to lay out the clinical relevance for you as a listener right from the start. Because when the general public thinks of the mortality of war, the immediate image is always kinetic, right? The battlefield, the blast injuries, the gunshot wounds.
Direct trauma.
Exactly. But the epidemiological reality tells a completely different story. The vast majority of war-related mortality is indirect.
Which is such a massive paradigm shift.
It really is. Patients do not just die from the trauma of weapons. They die from the massive public health collapse that is the calculated outcome of the conflict.
Yeah.
I mean, they die from cholera because the water treatment plant's power supply was destroyed. They die from preventable childhood diseases because the cold chain for vaccines was broken.
Right.
Or they starve because the agricultural system has been seeded with landmines.
So, to really analyze the etiology of this engineered pathogen, we need to establish our methodology up front. The source material covers some incredibly sensitive, highly charged geopolitical events.
Very much so.
We are going to be discussing the definitions of terrorism, the use of armed drones, and the specific military actions of various nations. But we are looking at this strictly as scientists.
Only as scientists.
Right. We are committed to academic precision and professional neutrality. We will analyze these events purely as factual data points, hazards, and epidemiological exposures. We are not here to endorse any nation's policies or, debate the morality of specific conflicts.
No, not at all.
Our only allegiance is to public health data and the prevention of morbidity and mortality.
And that professional neutrality is the absolute bedrock of epidemiology. When a public health official tracks a cholera outbreak, they do not judge the cholera, right?
They just map it.
Exactly. They map its spread, they understand its mechanism of transmission, and they engineer an intervention to stop it. We must apply that exact same clinical detachment to collective violence.
So let's trace the history of this clinical approach, because it feels so intuitive now to treat violence as a public health issue, but the medical and public health communities actually took quite a while to adopt this lens.
Well, they definitely did. The real paradigm shift began in 1966.
Okay.
That was the year the World Health Assembly first officially declared violence to be a major and growing public health problem across the world.
Wow, 1966. So before that, how was it viewed?
Prior to that, violence was largely viewed strictly through criminal justice or a military lens. But making a declaration and building a scientific framework are two very different things. It actually took nearly 4 decades to fully codify that approach into actionable science.
Decades.
Yeah. The defining moment came in 2002 when the World Health Organization published its first comprehensive world report on violence in health.
And that 2002 report is basically our diagnostic manual.
Exactly what it is.
Just like we categorize diseases to understand their pathophysiology and treatment pathways we need to know if we're looking at an autoimmune condition, an infectious disease, or an environmental toxicity. The WHO gave us a typology of violence.
Right.
They divided it into 3 broad categories based on the characteristics of those committing the acts.
The taxonomy is straightforward, but it's really profound.
Break it down for us.
Sure. So the first category is self-directed violence, which encompasses suicide or self-abuse. And we approach that with psychiatric and social interventions.
Okay.
The second is interpersonal violence. That encompasses things like intimate partner violence, child abuse, and elder abuse.
Right. More one-on-one.
Yes. And then the third category, which forms the core of the Oxford chapter we are analyzing today, is collective violence.
So let's put the textbook's definition of collective violence under the microscope because the phrasing is incredibly precise here.
It has to be.
It is defined as, and I'm quoting here, the instrumental use of violence by people who identify themselves as members of a group, whether this group is transitory or has a more permanent identity, against another group or set of individuals in order to achieve political, economic, ideological, or social objectives.
The hinge on which that entire definition turns is the word instrumental.
Instrumental.
Yeah. For a public health trainee, understanding the instrumental nature of collective violence is what distinguishes it from an individual pathology or, a random impulsive act of rage.
Right.
Instrumental means it is a calculated exposure. It is a tool deployed to achieve a specific end. It is a highly organized, heavily resourced system of harm.
So think about it like a disease classification system. If interpersonal violence is a localized infection, like a tragic, isolated event occurring in a specific tissue, then collective violence is a planned biological attack on the host.
That's a great way to look at it.
It requires logistics, supply chains, funding, and deliberate planning.
And that organized nature is precisely what makes it vulnerable to public health intervention.
Oh, so?
Well, if war is a calculated system of inputs and outputs, we can analyze those inputs and identify points of disruption.
Ah, I see.
And the 2002 World Report makes it clear that this definition goes far beyond traditional state-on-state warfare.
It covers a lot more ground.
It really does. It includes violent conflicts between nations, state and group terrorism, rape used as a calculated weapon of war, and the forced movement of large populations. All of these are instrumental methodologies deployed to achieve those political or economic objectives.
So if we agree that collective violence is this organized pathogen, we have to examine its pathogenesis. How does it physically attack the human body and the population at large?
Let's look at the direct health impacts and the shifting epidemiology of military operations.
Yeah, let's dive into that.
The clinical data from the 20th century reveals a staggering epidemiological shift. We mentioned the 191 million people who died directly or indirectly from conflict.
Right.
But the critical data point within that statistic is the demographic breakdown. More than half of those casualties were non-combatant civilians.
Wow. More than half. That fundamentally rewrites the morbidity and mortality burden of warfare, doesn't it?
It changes everything.
Because historically, prior to the 20th century, the direct kinetic casualties of war were overwhelmingly uniformed combatants fighting on, geographically defined battlefields.
Exactly.
I mean, civilians certainly suffered the secondary economic and agricultural consequences, but they were largely spared direct, intentional kinetic targeting.
That's right. But the epidemiological data pinpoints a very specific historical exposure that mutated this pathogen.
When did that happen?
The turning point was 1937, during the Spanish Civil War. This was the bombing of Guernica by Nazi forces supporting the nationalists.
Right, Guernica.
And the key here is that Guernica was not a military installation. It was a civilian population center.
So that is the exact moment the etiology of modern warfare changed.
From an epidemiological surveillance standpoint, yes, absolutely. From Guernica onward, moving into the extensive carpet bombing of densely populated cities in Europe and Japan during the Second World War, military operations increasingly began killing and maiming civilians through the purposeful targeting of non-military areas.
So the risk profile completely inverted.
Yes, the proportion of civilian deaths to total war-related deaths just skyrocketed. The civilian population was no longer adjacent to the battlefield. The civilian population became the battlefield.
Which forces us to confront a highly complex diagnostic overlap in the Oxford text, which is the distinction between war and terrorism.
This is a difficult area. Yeah.
The text defines terrorism as politically motivated violence or the threat of violence, especially against civilians, with the intent to instill fear.
And we have to maintain our strict objectivity here because the terminology is heavily politicized.
Right.
The text explicitly notes that definitions of terrorism are often highly partisan. It's the classic observation that one side's terrorist is frequently viewed as a patriot or a freedom fighter by the other.
Hmm.
But public health does not deal in political labels. It deals in mechanisms of harm.
Mechanisms of harm, I like that.
Yeah. And the mechanism here is the intent to instill fear in a civilian population. The text points out that this epidemiological mechanism encompasses violent acts conducted by recognized nation-states against civilians just as much as acts committed by subnational groups.
So mechanically speaking, the utilization of civilian terror is just another instrumental tool. Whether the explosive device is dropped from a multi-million-dollar state military aircraft or detonated in a public market by a non-state actor, the exposure pathway, the blast physics, the primary and secondary trauma, the psychological terror, it results in the exact same public health outcome.
It does, and the text emphasizes that the term terrorism has considerable overlap with the term war.
Right.
From a hospital's perspective, receiving mass casualties from a state-sponsored air raid or a subnational bombing requires the exact same triage protocols, the same surgical interventions, and the same long-term psychological support.
The pathogen behaves identically regardless of the political label applied to the vector.
Exactly right.
I want to push back on a specific phrase that dominates the public discourse around this. We constantly hear the term collateral damage.
Oh, yes, that term.
Right. It's used in press briefings to describe civilian deaths as if they are merely an unfortunate accidental side effect of targeting a military objective.
Right, and oops.
Exactly. But if we look at the epidemiology post-Guernica and we look at the sheer mathematics of modern conflict, isn't civilian death a primary, predictable feature of modern warfare's etiology rather than an accidental side effect?
The data supports that pushback entirely. I mean, when public health researchers analyze the statistics, when well over half of the 191 million dead in the 20th century were civilians, it becomes mathematically impossible to categorize civilian morbidity as a mere anomaly or an accident.
You just can't.
You can't. Whether a military force is intentionally targeting civilians to break societal morale, or they are utilizing heavy explosive weapons in densely populated urban centers where massive civilian casualties are a statistical certainty, the primary public health burden falls squarely on the non-combatant.
Yeah.
The text makes it unambiguous. Massive direct kinetic trauma to civilians is a defining characteristic of modern collective violence.
But the narrative gets even darker, because as horrific as the direct trauma is, the blast injuries, the amputations, the burns, the true mass mortality of war doesn't come from the explosions.
No, it doesn't.
It comes from what happens after the smoke clears. If the direct impacts are the initial infection, the indirect effects are the syndemic collapse of the host.
Syndemic is the exact clinical framework we need here.
Can you define that for our listeners?
Absolutely. For our listeners, a syndemic occurs when two or more diseases or health conditions interact synergistically, exacerbating the overall burden of disease. And this interaction is usually driven by adverse social or environmental conditions.
Okay.
War is the ultimate engine for syndemics. We have to shift our focus from direct trauma to the systemic collapse of public health infrastructure.
Let's trace the pathophysiology of this societal collapse. The text highlights the destruction of critical infrastructure. We're talking food and water supply systems, healthcare facilities, sewage disposal, power plants, and electrical grids.
Let's walk through the causality chain of a syndemic for a public health trainee.
Yeah, let's map it out.
Okay. The initial exposure is the destruction of municipal power grid. The immediate outcome is not just a loss of lighting.
Right, it's so much more than that.
Without electricity, the municipal water purification plants cease to function. Without purification, the civilian population is forced to rely on contaminated surface water or untreated wells.
Which leads to
The secondary outcome: a massive, rapid onset outbreak of waterborne diseases like cholera, typhoid, or dysentery.
and it compounds from there. Because the power grid is down, the regional hospitals cannot run ventilators, they cannot sterilize surgical equipment, and crucially, the cold chain for vaccines is completely destroyed.
Exactly.
So now, in the midst of a cholera outbreak, you are also seeding future outbreaks of measles and polio because the pediatric population is no longer immunized.
Furthermore, the destruction of transportation and communication infrastructure means that agricultural products cannot reach urban markets.
Right.
This leads to acute, widespread malnutrition. And we know clinically that severe malnutrition aggressively suppresses the immune system.
Right, so it transforms what might be a survivable bout of diarrheal disease into a lethal event, particularly for pediatric populations.
Exactly. The textbook explicitly notes that much of the morbidity and mortality during war, especially among vulnerable civilian demographics, is the direct, predictable result of this cascading infrastructure damage.
What's fascinating from a systems perspective is that the public health impact actually begins before a single shot is fired.
That's a really important point.
The text introduces a concept that is absolutely critical for health professionals: militarism and economic diversion. The sheer preparation for war diverts massive human, technological, and financial resources away from human welfare.
The opportunity cost of war preparation is immense. A nation preparing for armed conflict must divert its own vital economic resources away from its population's baseline well-being to build and maintain a military apparatus.
It functions exactly like an autoimmune disease on a societal level.
Oh, that's a perfect analogy.
Right. In an autoimmune response, the body's immune system mistakenly attacks its own healthy tissues, diverting immense physiological energy into a destructive, self-harming process. A society preparing for war behaves the exact same way. It drains its own lifeblood to feed the defense mechanism.
And the text provides a highly illustrative example of this economic diversion.
Let's hear it.
It cites data noting that in recent years, Angola, which is a developing nation with significant public health challenges, spent $196 per capita on military expenditures, but only $183 per capita on health.
Wait, $196 on the military and only $183 on health.
Exactly.
Wow.
When a government prioritizes military spending over basic sanitation, primary education, and maternal health care, it is actively degrading its own baseline public health.
Yeah.
The true cost of those diverted funds isn't just measured in dollars. It is measured in preventable infant mortality, untreated chronic disease, and lower life expectancy.
This systemic degradation forces a symptom that is perhaps the most visible indirect effect of war-forced migration. When the infrastructure collapses, when the food supply is disrupted, and when the violence escalates, the population must flee.
Right.
And the epidemiological scale of this displacement is almost difficult to conceptualize.
The text notes there are 10.5 million refugees and 27.5 million internally displaced persons, or IDPs, worldwide directly as a result of conflict.
We need to clearly delineate between those two populations for our public health practitioners, because that legal distinction dictates the health resources, the legal protections, and the overarching public health response available to those people.
The differentiation is absolutely vital. A refugee is defined as someone who has been forced to flee their country of origin and has successfully crossed an international border.
Okay, so they've crossed a border.
Yes.
Yeah.
Because they are outside their country of nationality, they frequently fall under the mandate of international bodies like the United Nations High Commissioner for Refugees.
Right.
While conditions in refugee camps are often incredibly difficult and resource-constrained, refugees possess a certain level of recognized international legal status and access to global humanitarian aid networks.
And an internally displaced person, an IDP.
An IDP has been forced to flee their home to escape the violence, but they have not crossed an international border. They remain trapped within the borders of their own country.
Oh, wow.
The text emphasizes that these 27.5 million IDPs are frequently in a far more vulnerable public health position than refugees.
Why is that?
Because they do not have seamless access to international humanitarian aid, safe water protocols, structured health care, or protected shelter. Because they are still located inside the active conflict zone.
Right.
They may even be subject to the governance of the very state or non-state actors that caused their displacement in the first place.
The demographic concentration is startling, too. The text highlights that approximately 9.9 million of these IDPs are concentrated in just 5 nations: the Democratic Republic of Congo, Iraq, Somalia, Sudan, and Syria.
Just 5 nations.
Yeah. And when you look at the epidemiological profile of these displaced populations, it is heavily skewed. The vast majority are women, children, and the elderly.
When analyzing the public health burden of displacement, we really must differentiate between incidence and prevalence.
Let's break that down.
So the incidence of displacement refers to the acute new cases, the thousands of families fleeing a city today because it is actively under artillery fire.
Okay.
The required public health intervention there is acute trauma care, emergency thermal shelter, and the rapid deployment of clean water to prevent devastating outbreaks of diarrheal disease within the first 72 hours.
But the prevalence of displacement requires a completely different medical approach. We are talking about the long-term burden of a refugee population that might be living in a structured camp in a neighboring host country for 10, 20, or even 30 years.
Exactly. A refugee camp that exists for 2 decades, ceases to be an acute emergency. It becomes a parallel society, basically a permanent municipality. So the public health focus has to shift dramatically. You move from acute trauma triage to managing chronic, non-communicable diseases like diabetes and hypertension.
Right.
You have to establish permanent maternal and child health services, address intergenerational malnutrition, and perhaps most challengingly, deal with the profound compounding mental health trauma of prolonged multi-generational displacement.
And while we are analyzing these systemic indirect effects, we have to look at the environmental and energy footprint of militarism.
Oh, this is a huge piece of it.
We tend to think of the environmental damage of war as something that only happens on the battlefield, but the preparation for war is an environmental catastrophe all on its own. The text makes it clear that hazardous wastes from military operations represent massive, long-term contaminants of air, water, and soil.
The text utilizes domestic sites in the United States to illustrate the environmental cost of militarism, demonstrating that this hazard is not confined to foreign conflict zones.
Give us some examples.
For instance, at the Otis Air Force Base in Massachusetts, the local groundwater was heavily contaminated with trichloroethylene, which is a probable human carcinogen.
Wow.
At the Rocky Mountain Arsenal in Colorado, researchers found that 125 different toxic chemicals were routinely dumped over a period of 30 years.
125 different chemicals.
Yeah. And at the McCord Air Force Base in Washington State, environmental sampling revealed extremely high concentrations of benzene, a known highly potent human carcinogen. Yeah. This is the latent toxic footprint required simply to maintain a military posture.
The energy consumption required for these operations is staggering, too. The text notes that a single armored division, which consists of roughly 348 battle tanks operating for just one day, consumes more than 2.2 million liters of fuel.
In one day.
One day. And a single carrier battle group consumes more than 1.5 million liters a day. The subsequent emissions of carbon monoxide, oxides of nitrogen, and sulfur dioxide into the atmosphere are just astronomical.
Therefore, when we conceptualize the indirect effects of war, we really must understand it as a comprehensive systemic. It encompasses the deliberate collapse of healthcare infrastructure, the systemic diversion of national wealth away from medicine, the forced migration of tens of millions of the most vulnerable demographic groups, and the long-term toxic degradation of the natural environment.
So if collapsed infrastructure, displaced populations, and poisoned groundwater are the systemic symptoms of this societal disease, we have to ask, what is the actual mechanism of transmission? How is this trauma being physically delivered?
That brings us to Section 4, weapon systems.
Right. In epidemiological terms, we are analyzing the specific vectors of morbidity.
Viewing weapon systems as vectors is a highly practical clinical framework. Just as the Anopheles mosquito is the biological vector that delivers the malaria parasite, weapon systems are the engineered vectors that deliver the pathogen of collective violence.
I love that framing.
And just like biological vectors, we must classify these weapons to understand the specific epidemiological threats, injury patterns, and environmental hazards they pose.
Let's begin with the most ubiquitous and, frankly, the most lethal category. Conventional weapons, specifically small arms and light weapons, or SALW. This classification includes pistols, assault rifles, machine guns, and light mortars.
The text highlights a profound observation by former UN Secretary General Kofi Annan. He stated that small arms could accurately be described as the true weapons of mass destruction.
That's a strong statement.
It is, but look at the data. He said this because the fatalities they produce globally dwarf that of all other weapon systems, and in most years greatly exceed the toll of the atomic bombs that devastated Hiroshima and Nagasaki.
That quote should radically reorient our public health threat perception. We spend decades and billions of dollars terrified of a category, a biological attack or a rogue nuclear detonation.
Right.
We build immense national security apparatuses around those low-probability, high-consequence events. Yet the epidemiological data clearly demonstrates that cheap, easily transportable, mass-produced conventional small arms are currently causing the actual daily mass fatalities worldwide. We are practically misdiagnosing the primary pathogen.
We really are. The global proliferation of small arms is the constant underlying exposure that drives the bulk of war-related mortality, particularly in developing nations and sub-state conflicts.
So what's the intervention?
The text points to a significant public health intervention in this area. The 2013 Arms Trade Treaty, which was approved by the UN General Assembly.
Okay.
This treaty attempts to regulate the international trade of conventional weapons by legally linking arms exports to the human rights records of the purchasing countries. The aim is to stem the flow of vectors to regions experiencing acute conflict or state-sponsored terrorism.
But conventional weapons extend far beyond small arms, right? They include the heavy artillery, unguided bombs, and high explosives that account for the overwhelming majority of environmental destruction.
Yes, absolutely.
The text mentions the extensive carpet bombing of cities in World War II, the deliberate ignition of more than 600 oil well fires in Kuwait during the Persian Gulf War that caused widespread, severe respiratory ailments, and the massive bombing of mangrove forests during the Vietnam War.
The destruction of the mangrove forests in Vietnam provides a perfect illustration of how a mechanical vector creates a long-term biological hazard.
How so?
The text notes that the immense bomb craters left in the forests have remained for decades. These craters fill with stagnant rainwater, which then serves as ideal unmanaged breeding grounds for mosquitoes.
Oh, wow.
So the initial vector, the explosive bomb, permanently altered the local ecology to create a thriving environmental niche for the biological vector of malaria.
That is exactly the kind of long-term systems thinking public health requires. Let's examine a much more modern vector discussed in the text, armed drones.
The technological shift here is really significant. We're moving from utilizing unarmed drones purely for aerial surveillance and intelligence gathering to deploying armed drones to execute targeted lethal strikes.
Right.
The text specifically discusses the United States' use of armed drone strikes since 2004, primarily operating over Pakistan to target suspected militants.
And this introduces a massive epidemiological controversy regarding the categorization of casualties, specifically non-combatants.
A huge controversy, yes.
The text cites widely conflicting data, which represents a classic public health surveillance failure. On one hand, the U.S. Central Intelligence Agency contended that strikes in Pakistan since May 2010 killed more than 600 militants and 0 non-combatant civilians.
Zero.
Conversely, the Bureau of Investigative Journalism in London reported that out of 1,842 people killed in over 230 strikes in Pakistan since 2008, while the majority were indeed militants, at least 218 may have been non-combatant civilians.
For an epidemiologist, encountering such a massive discrepancy in mortality, data highlights the immense, sometimes insurmountable difficulty of conducting accurate public health surveillance in active conflict zones, especially when the lethal exposure is delivered remotely.
Yeah.
It raises profound questions about post-strike surveillance methodology, how a combatant is defined in the absence of a uniform, and the transparency of the data used to justify the public health impact of the intervention.
Let's transition to the vector that casts the most terrifying shadow over global health. Nuclear weapons.
Yes.
The sheer scale of the potential morbidity here is difficult to process. The text states there are an estimated 19,000 nuclear warheads globally, possessed by at least 9 sovereign nations.
We must contextualize this exposure historically, though. The global nuclear stockpile actually reached its explosive peak in 1960.
Okay, 1960.
At that time, the combined explosive capacity was equivalent to 20,000 megatons.
Can you put that into a clinical perspective for us?
Yeah, to make that abstract number clinical, that is equivalent to 1.4 million of the atomic bombs dropped on Hiroshima.
1.4 million.
Yeah.
The public health outcomes of the detonations over Hiroshima and Nagasaki in August 1945 are starkly documented in the text. Approximately 200,000 people died immediately, the overwhelming majority of whom were civilians.
Right.
This was followed by a cascade of lasting thermal injuries, secondary deaths from acute radiation syndrome, massive infrastructural devastation, and widespread lingering radioactive contamination.
It's horrific.
But crucially, the text emphasizes that it is not just the wartime detonation that causes morbidity. The mere testing of these weapons is a profound public health hazard.
Yes, the testing alone.
The text notes that atmospheric testing of nuclear weapons led to demonstrable increases in leukemia and other cancers among downwind civilian populations, specifically documenting the devastating effects of exposure to the radioactive isotope iodine-131 on the thyroids of children.
Furthermore, the industrial processes of producing and eventually disposing of these weapons constitute a permanent, incredibly complex public health burden. We must rigorously differentiate between hazard and risk here.
Okay, let's do that.
The text provides the example of Chelyabinsk in Russia, a region heavily contaminated by a massive nuclear weapons production facility. Ambient radiation near the Teka River in Chelyabinsk was documented at 28 times the normal background level.
28 times.
That elevated radiation is the hazard. The risk is the statistical likelihood of the local population actually being exposed to that radiation through their drinking water supply or by consuming locally grown agricultural products.
The United States manages its own legacy sites, too. The text mentions the documented leakage of radioactive materials into the Columbia River from the Hanford site in Washington state.
Right.
And then we have the immense challenge of the disassembly process. The Pantex plant in Texas is responsible for dismantling thousands of retired warheads.
Yeah, Pantex.
They currently have approximately 14,000 plutonium pits. These are the hollow spherical shells of plutonium that act as the trigger for the thermonuclear weapons sitting in interim staging. And the text explicitly notes that plutonium has a half-life of 24,000 years.
We need to pause and deeply consider the public health implications of a 24,000-year half-life.
I mean, it's almost incomprehensible. We are talking about roughly 1,000 generations of human beings.
Exactly. It means that the geopolitical decision to engineer this specific weapon system in the 1940s created an acute environmental health hazard that must be safely managed, structurally contained, and actively guarded by human societies for longer than the entirety of recorded human civilization thus far.
That's wild.
How do you design an epidemiological warning sign for a toxic site that will outlast the current iterations of human language? It is the ultimate multi-generational legacy of morbidity.
Adjacent to nuclear weapons, we must discuss radiological weapons, specifically depleted uranium, or DU, munitions. The text explains that DU is uranium from which the highly radioactive isotopes have been extracted, leaving a material that is incredibly dense. Militaries use it as a casing for armor-penetrating artillery shells.
Its physical properties make it a highly effective military tool. It is extremely dense, it easily slices through heavy tank armor, and it is pyrophoric.
Pyrophoric, meaning?
Meaning the friction of impact causes it to spontaneously burst into flames, incinerating the target.
Wow.
The U.S. and the U.K. utilized DU shells extensively in the Persian Gulf War, the Iraq War, and the conflict in Kosovo. While the nations deploying these munitions consider their use legally permissible under international law, the public health reality is a lot more complex.
Right.
DU remains mildly radioactive and is highly chemically toxic as a heavy metal. It has been demonstrated to aerosolize upon impact and subsequently contaminate soil and local groundwater in the specific regions where it is heavily deployed.
Let's examine chemical and biological vectors. The text provides a fascinating yet incredibly grim historical timeline here.
It does.
For chemical weapons, it points to the widespread use of the defoliant agent orange by the U.S. military during the Vietnam War. It was designed to kill the dense jungle vegetation to deny cover to enemy forces, but the epidemiological data suggests it may have led to excessive rates of birth defects and specific cancers among the local Vietnamese residents and the military personnel who handled it.
Right.
The text also highlights the evolving non-state threat, citing the Aoshinrikyo cult's deployment of sarin nerve gas in the Tokyo subway system in the 1990s. That attack killed 19 people and injured thousands, demonstrating the accessibility of chemical vectors to subnational groups.
And the history of biological agents is a masterclass in understanding the instrumental use of infectious disease.
Take us through it.
The text traces this evolution all the way back to ancient warfare. In 1346, during the siege of the seaport of Kaffa, Mongol forces literally catapulted the infectious cadavers of plague victims over the city walls to infect the defending population.
Wow.
That is arguably the earliest recorded form of instrumental biological warfare. Fast forward to 1942, and the UK and US militaries intentionally contaminated Grunard Island off the coast of Scotland with highly resilient anthrax spores during biological weapons testing, rendering the island uninhabitable for decades.
And the text details a specific, highly illustrative epidemiological event that occurred in 1979 in the Soviet Union, the accidental release of anthrax spores from a military biological weapons facility near the city of Sverdlovsk.
The Sverdlovsk event is a cornerstone epidemiological case study.
Why is that?
Because the accidental airborne release resulted in at least 77 documented cases of severe inhalation anthrax and 66 deaths among the local civilian population living downwind of the facility. It conclusively proved the lethal mass casualty efficacy of aerosolized biological agents in an urban environment. More importantly, it highlighted the extreme inherent public health risk posed simply by the laboratory research, cultivation, and storage of these highly virulent pathogens, even in the absence of intentional deployment.
To structure our threat perception regarding these biological vectors, the U.S. Centers for Disease Control and Prevention, the CDC, has categorized biological agents into three distinct tiers.
Let's go through them.
Category A includes the highest priority agents. These are pathogens that pose a massive risk to national security and public health because they can be easily disseminated or transmitted from person to person, result in high mortality rates, and cause public panic.
Boy.
This includes anthrax, botulism, plague, smallpox, tularemia, and viral hemorrhagic fevers like Ebola.
Right. Category B includes moderately easy to disseminate agents that result in moderate morbidity rates and low mortality rates.
Yeah.
This includes threats like Q fever, typhus, and critical food safety threats such as Salmonella and E. coli. And finally, Category C encompasses emerging pathogens that could potentially be genetically engineered in the future for mass dissemination due to their availability, ease of production, and potential for high morbidity and mortality. This includes viruses like Nipah or emerging hantaviruses.
We must cover one final insidious vector detailed in this section: anti-personnel landmines. The text quotes a chillingly accurate description of them. They are weapons of mass destruction, one person at a time.
That is exactly what they are. The epidemiology of landmine injuries is devastatingly consistent. There are tens of millions of these devices deployed across 72 different countries.
Tens of millions.
Yeah, and they persistently injure or kill approximately 4,000 people annually, year after year.
And who is getting injured?
The vast majority of these victims are not soldiers. They are civilians, primarily the rural poor who rely on agriculture. And tragically, the data shows that about 1/4 of all landmine victims are children.
This brings us perfectly back to your distinction between hazard and risk. A buried landmine is a latent hazard. It sits completely dormant, hidden in the soil for decades after a conflict ends.
Right.
But the risk, the actual probability of an adverse health event, spikes exponentially when a peace treaty is signed and internally displaced persons or refugees finally attempt to return home. They must cultivate that exact same land to survive and feed their families. At that point, the risk of a returning farmer stepping on a forgotten mine becomes almost unavoidable.
And the economic asymmetry of this vector is staggering.
How so?
The text notes that while a basic anti-personnel landmine costs only a few dollars to mass produce and deploy, it costs over $1,000 to meticulously locate and safely remove a single mine.
Wow.
This massive cost discrepancy makes large, vital swaths of agricultural land permanently uninhabitable, thereby crippling the post-war economic recovery and perpetuating the syndemic of poverty and malnutrition long after the formal hostilities have ceased.
We have spent this deep dive rigorously diagnosing the pathogen of collective violence. We have studied its shifting epidemiology and its systemic, syndemic impacts. We have identified and categorized its specific mechanical and biological vectors, from small arms and drones to plutonium and aerosolized anthrax.
Right.
In public health, a precise diagnosis demands an effective treatment plan. If we can map the etiology of this pathogen, we can design specific public health interventions to arrest its spread. This moves our discussion from pathology to treatment, bringing us to Section 5, the role of public health in addressing war.
This is where we apply the core clinical framework of prevention.
Okay.
The health deficits, the massive demographic displacements, and the environmental degradation created by collective violence can seem utterly insurmountable. However, the text insists that standard, proven public health principles can be successfully applied to mitigate this threat.
What are those principles?
Those foundational principles are rigorous surveillance and documentation, sustained education and awareness campaigns, and relentless advocacy for sound, health-promoting public policies.
For surveillance, the text points to the critical use of household cluster surveys to accurately estimate civilian casualties, a methodology that was deployed to great effect during the Iraq War. As clinicians know, you cannot intervene in an epidemic if you do not have accurate mortality and morbidity data.
Exactly.
But the absolute core of this final section relies on a framework that every medical and public health student must memorize: the 4 levels of prevention: pre-primary or primordial, primary, secondary, and tertiary prevention.
I want to heavily emphasize this specific structural framework because it is how you must organize your clinical thinking regarding conflict.
Let's lay it out.
Let us define them clearly as they apply to the pathogen of collective violence.
Yeah.
Pre-primary or primordial prevention consists of removing the deep underlying structural and societal conditions that breed war in the first place.
Okay.
Primary prevention is preventing the specific exposure, stopping the weapons from existing or stopping the finger from pulling the trigger. Secondary prevention is minimizing the harm, limiting the spread and protecting the vulnerable after the disease process, the act of war, has begun. And tertiary prevention is the long, difficult process of physical rehabilitation and societal reintegration after the acute event has ended.
Let's ground this in a clinical analog. Think of it like managing cardiovascular disease.
That's a great way to do it.
Tertiary prevention is performing the quadruple bypass surgery after the patient has suffered a massive myocardial infarction. In our context, that is rebuilding a bombed city, clearing the landmines, and treating the blast amputees.
Right.
Secondary prevention is putting a stent in when the patient presents with severe angina, minimizing the damage during an acute ischemic event. That is enforcing the Geneva Conventions to protect civilians and hospitals during active, ongoing combat.
Exactly.
Primary prevention is prescribing daily statins to lower cholesterol before a dangerous blockage ever forms. That is successfully negotiating the Non-Proliferation Treaty to legally stop the spread of nuclear weapons.
And primordial.
But primordial prevention is radically redesigning our urban environment so people can walk safely, access fresh, healthy food, and not be ground down by chronic, stressful poverty. In the macro context of war, primordial prevention means actively ending global poverty, ensuring equitable resource distribution, and fighting systemic social injustice.
That is a highly precise and clarifying analogy. Let us look deeper into primordial prevention as outlined in the Oxford text.
Yeah, let's look at the root causes.
It demands that we address the true root causes of collective violence. The Carnegie Commission on Preventing Deadly Conflict identified specific, measurable societal factors that place nations at high risk for violent conflict.
What are they?
These include a profound lack of democratic processes and unequal access to political power, particularly when that power is segregated along ethnic or religious lines. It includes massive social inequality and desperate competition for declining resources. It includes the monopolistic control of valuable, exportable natural resources, like oil, timber, or precious gems, by a single elite group. And it includes rapid, unmanaged demographic changes that outstrip a fragile nation's ability to provide basic services, education, and employment for its youth.
The text makes a stark, almost unbelievable financial comparison regarding our global commitment to primordial prevention. It notes that the entire United Nations system, which is explicitly tasked with preventing war, protecting global human rights, and promoting sustainable societal development through vital agencies like UNICEF, the WHO, and the UNHCR, operates on roughly $5 billion a year.
$5 billion.
By devastating comparison, annual global military expenditures top $2 trillion.
That financial ratio is a profound indictment of global public health priorities, as the text explicitly calculates that $2 trillion in global military spending could entirely fund the United Nations system for roughly 400 years.
400 years.
Yeah. If we accept the epidemiological premise that poverty, resource scarcity, and socioeconomic disparities are the leading underlying vectors of war, then radically redistributing that wealth and fully funding sustainable development programs is objectively the most effective primordial public health intervention available to humanity.
Stepping down the framework to primary prevention, the statins in our cardiovascular analogy, this level is about preventing the specific exposures primarily achieved through complex international treaties. The text lists several crucial historical agreements that attempt to legally outlaw or severely restrict the vectors we discussed earlier.
For managing the nuclear vector, the text details the Partial Test Ban Treaty of 1963, which banned atmospheric, underwater, and space testing to halt the widespread radioactive fallout that was poisoning the global environment. Then there is the Comprehensive Nuclear Test Ban Treaty of 1996, which legally bans all nuclear explosions anywhere on Earth. However, the text notes a critical failure. It has not yet entered into force because several key nuclear-capable nations, including the United States, China, and India, have failed to ratify it.
That's a huge gap.
It is, and perhaps most importantly, the Non-Proliferation Treaty of 1968, which attempts to restrict the global transfer of nuclear technology while simultaneously committing existing nuclear weapon states to eventual total disarmament.
For managing chemical and biological vectors, we have the Chemical Weapons Convention of 1997, which mandates the destruction of all chemical stockpiles and production facilities, monitored by the Organization for the Prohibition of Chemical Weapons. And we have the Biological and Toxic Weapons Convention of 1975.
We must note, as the text does, that the compliance and verification measures for the Biological Weapons Convention are notoriously weak, relying heavily on self-reporting.
Wow.
However, the text makes a brilliant deeply integrated public health point regarding bioweapons. The absolute best ultimate defense against an intentionally induced engineered epidemic is actually just building incredibly strong, globally integrated preventive public health capabilities designed to deal with natural infectious diseases.
That makes total sense.
Right. If you have a robust, rapid response global health system capable of immediately detecting and containing a natural outbreak of Ebola or pandemic influenza, you have effectively neutralized the strategic threat of a biological weapon.
And finally, for primary prevention, the text highlights the Ottawa Treaty, the Anti-Personnel Mine Ban Convention of 1997. While 160 nations are parties to it, attempting to eradicate this insidious vector, several major global military powers, including the United States, Russia, and China, have refused to sign it.
As we step down the prevention ladder, we inevitably reach secondary prevention. If primordial and primary interventions fail, and armed conflict erupts, the singular goal becomes harm reduction.
Harm reduction.
In this context, secondary prevention involves strengthening global adherence to international humanitarian law, specifically the Geneva Conventions. This legal framework is designed to strictly protect non-combatants, absolutely prevent the targeting of medical facilities and transport, and limit wanton environmental destruction during active hostilities.
And lastly, tertiary prevention. The war is over, the societal heart attack has occurred. How do we rehabilitate the surviving patient? The text mentions comprehensive physical and social rehabilitation for injured individuals, the painstaking, expensive process of clearing millions of landmines, the environmental remediation of highly toxic military sites like we discussed at Chelyabinsk, and massive macro-level economic interventions like the Marshall Plan deployed after World War II to rebuild entirely shattered economies.
It's a massive undertaking.
It is. But it also highlights a crucial, often overlooked societal intervention: truth and reconciliation commissions, like the profoundly impactful one instituted in South Africa following the end of apartheid. These are designed to heal deep, generational social trauma and actively prevent the resumption of the cycle of violence.
The text concludes this entire framework by emphasizing the indispensable role of non-governmental organizations, or NGOs, across all 4 phases of prevention.
They really are on the front lines.
Civil society organizations are the ones actively mitigating the immediate consequences of conflict, conducting the rigorous field research on the health impacts, providing the direct, life-saving humanitarian aid in refugee camps, and relentlessly advocating for policy changes at the UN. They are the frontline public health workers actively treating the pathogen of war.
Which brings us to a powerful, unifying synthesis of this entire Oxford chapter. By treating war not as an inevitable political reality, but as a preventable public health crisis, clinicians, epidemiologists, and public health professionals are given a profound, actionable mandate.
Absolutely.
Our job isn't merely to passively heal the wounded after the bombs fall. Our job is to rigorously document the epidemiology of the violence, systematically dismantle the vectors of morbidity, aggressively address the primordial causes of societal infection, and actively advocate for peace as a fundamental, non-negotiable pillar of global health.
Precisely. War prevention and structural peace building are not adjacent to public health. They are fundamentally public health priorities.
All right, let's pressure test this framework before we go. We are going to run through a few rapid single best answer style recall prompts based directly on the concepts we just mapped out. I will ask the question, take a beat to let you lock in your diagnostic answer, and then we will provide the solution, the reasoning, and point you back to the specific section of the text. Ready?
Let's do it.
Prompt 1. If I am a public health trainee looking at the WHO typology of violence, and I am analyzing an event defined specifically by its instrumental use by a group against another group to achieve a specific objective, what am I diagnosing? Take a second to think about it.
You are diagnosing collective violence. The key word you must key in on is instrumental, meaning it is a calculated, organized exposure, distinguishing it from interpersonal or self-directed violence. You can review the WHO typology in the definitions section of Chapter 9.6.
Prompt 2. What specific geopolitical event in 1937 marked a dramatic epidemiological shift toward the intentional targeting and mortality of civilians in warfare, fundamentally changing the morbidity burden? Lock in your answer.
The answer is the bombing of Guernica, Nazi forces bombed this non-military target in Spain, marking the beginning of a modern shift where civilian deaths became a primary feature rather than just an incidental consequence of military operations. Refer back to the direct consequences section for more on this epidemiological shift.
Prompt 3. In our clinical frameworks of public health, successfully negotiating and implementing a comprehensive nuclear test ban treaty represents which specific level of prevention? Take a beat.
That represents primary prevention. It is designed to prevent the specific exposure, in this case, the deployment, testing, or proliferation of the weapon from occurring in the first place. You can review the levels of prevention section to contrast this with primordial or secondary prevention.
Prompt 4. According to the text, which class of weapons is responsible for a global fatality toll that dwarfs that of all other weapon systems, effectively acting as the most lethal current vector of collective violence? Think about it.
The answer is small arms and light weapons, or FALW. Despite the massive security apparatus built around nuclear or biological agents, cheap, conventional firearms are the primary vector driving daily mass casualties in global conflicts. Review the weapon system section for the data on this vector.
Prompt 5. When analyzing the epidemiology of forced migration, what is the critical difference in legal status and public health vulnerability between a refugee and an internally displaced person, or IDP? Lock it in.
The answer is that an IDP remains trapped within the borders of their own country, whereas a refugee has successfully crossed an international border. Because IDPs remain inside the active conflict zone, they often lack the recognized legal status and the access to international humanitarian aid, safe water protocols, and shelter that are generally available to refugees. Refer back to the indirect effects section for the statistics on displaced populations.
Excellent. Now, before we sign off, we want to leave you with one final provocative thought to mull over, something that builds logically on everything we have mapped out today.
Consider the long shadow of conflict on a molecular level. Today we have discussed macro-level impacts, destroyed electrical grids, poisoned groundwater, and the failure of international treaties.
Right.
But emerging research in the field of epigenetics suggests that the extreme sustained stress, massive trauma, and severe starvation associated with war can actually alter the gene expression of the survivors.
Alter their gene expression.
Yes. This means that the profound biological trauma of a conflict can be structurally passed down to generations who were never even born during the war. If collective violence alters our very DNA, then peacebuilding isn't just a political ideal or a massive infrastructural project. It is, quite literally, the ultimate form of genetic medicine.
War is not merely a geopolitical event. It is an engineered pathogen. Thank you for joining us on this deep dive. Here are the details of this episode.
War. Title: War Byline. Medlock Holmes investigates war as a public health catastrophe, examining mortality, displacement, infrastructure collapse, and the long shadow of conflict on population health. Episode description: War reshapes the health of populations at every level. Beyond battlefield deaths, conflict drives displacement, famine, infectious disease outbreaks, environmental contamination, collapse of health systems, and generational trauma. This chapter examines the epidemiology of armed conflict, including direct mortality, civilian injury, landmines, chemical and biological weapons, and the destruction of water, sanitation, and health infrastructure. The ripple effects extend into forced migration, malnutrition, interrupted vaccination programs, and long-term mental health consequences. We explore international humanitarian law, global treaties on weapons, and the role of humanitarian assistance. War is framed not only as geopolitical failure, but as a predictable generator of preventable public health crises. Public health in conflict becomes a discipline of preparedness, protection, reconstruction, and accountability. Key takeaways: the majority of war-related deaths are indirect, resulting from disease, malnutrition, and infrastructure collapse. Civilian populations, particularly women and children, bear disproportionate burden. Forced migration and displacement profoundly affect health outcomes. Landmines, chemical weapons, and biological agents create long-term public health threats. Health system destruction amplifies mortality from otherwise preventable conditions. International humanitarian law and coordinated humanitarian response are central to mitigation. War prevention and peacebuilding are fundamentally public health priorities.